Okay, good evening, my colleagues here. Good evening, Dr. Mervat, who asked me a few days ago to present a challenging case actually of uh, atrial fibrillation ablation that we have a lot, but I choose this case actually because I've done it like 5 years ago when I didn't have much experience in persistent atrial fibrillation. Actually, the end result of this case actually shaped a lot of my practice after this in atrial fibrillation ablation. So actually, he was a cousin of one of our colleagues at the National Heart Institute. Actually, he was 63 years old 5 years ago, with only a history of past history of hypertension. So this patient, 3 years before he was presented to me, he was having attacks, rare attacks of paroxysmal atrial fibrillation. Um, his cousin, who was a cardiosurgeon, actually tried all the antiarrhythmic drugs in the market here, but the patient still had these attacks, which was becoming more and more frequent. When actually he consulted me for the patient, actually it was like few months before that the patient went into persistent fibrillation, and he tried to cardioversion using cardioversion, DC cardioversion, which was facilitated with amiodarone, but actually nothing actually was capable to put him back in sinus rhythm. So in the very beginning, we adopted for rate control, but despite that the patient had an optimal rate control, the patient actually completed heart failure symptoms with ANIHA class 3. I was really hesitant to go, and especially that the echo actually showed that the patient had dilated both atria. And my first actual opinion was to maintain the medical treatment, but again, I decided to go. Well, am I going to make an ablation or not? That was 5 years ago, and well, my first intuition was to make a cardiac MRI because on the images of the echo, and with my experience, sometimes when you see such case, you have to eliminate, especially in young patient, uh, an infiltrative heart disease, which can be presented in the very beginning, actually, something like the amyloidosis, for example, with an atrial arrhythmia. So I did the cardiac MRI for that purpose first, and I asked the radiologist to look for the atrium if she's capable or not. And actually, she looked for the MRI, and she told me that actually that the both atria actually was healthy. With the left atrium, there have been just focal enhancement around the ostium of the left pulmonary veins and the left lateral walls, as well as the posterior wall. So this is an image of his TEE on the left atrium that I programmed it before just the ablation. I decided to go actually because there have been no cardiac amyloidosis. Well, the first images that I didn't show here, there have been heavy smokes in the left atrium, and that's why I changed it the NWAC into Marivan actually, and I targeted an INR from 3 to 3.5 for a couple of months before going for an ablation. And just before the ablation, I did a TE, and there had been no contrast. And then I decided to go for the ablation. At this time, well, we still had the Lasonab actually in the market. We used the Smart Touch catheter for a cart system, and we didn't have at this time actually the ablation index in our carto. So I just contented to use the VZTag parameters that was recommended on previous study, and I went to use actually a voltage mapping just to confirm the result of the MRI and to see and the voltage mapping on the carto. And here you see actually, just remember that this voltage mapping, as I said, this patient was having an atrial fibrillation, and it was very and we failed to put him back in sinus rhythm with cardioversion facilitator medication. So I used actually a little bit of the numbers and the limits of the scar tissue at 0.01, not the zero point 0.1 that we use it in sinus rhythm to explore the low voltage area in the atria. And for my surprise, actually, I can see it. I saw it actually on the car systems that actually the result of the voltage mapping, it actually coincided with the what was found on the cardiac MRIs. We can see it here with the anterior wall of the patient, which has a normal voltage, and the posterior wall of the patient, there is a low voltage area around the pulmonary veins and the posterior wall of the left atrium. So this is the VZ-tag parameters that we used for the ablation, with a maximum distance of 4 millimeter and a minimum time for 15, with a minimum force for 5 grams. So we want to make the classical waka along the post-pulmonary veins. Of course, sometimes it's difficult to know if you achieved a pulmonary venous isolation. The patient is in atrial fibrillation. What happens in this case that after we do the ablation, if the patient was not in sinus rhythm and we cardiovert him, that we go for a verification after putting the patient back into sinus rhythm. But sometimes you get lucky that after the ablation and while your catheter is inside the vein, you can see an isolated pulmonary venous potential like what we see it here, which actually confirmed that you did an entrance block. And I was lucky to see it in 3 of the 4 veins, actually to see this isolated pulmonary venous potential. After this, I went to do an ablation of the posterior wall. And the techniques, there have been different techniques actually. The one that is mostly used widely, I think like 95% of cases, is like to draw a line of ablation from the left superior to the right superior, and from the left inferior to the right inferior pulmonary veins, and mostly try to put your ablation point around or inside the area of low voltage. We cardioverted the patient after this, and it was the first time in 1 year that the patient went into sinus rhythm. And 3 months after ablation, of course, the patient was on anticoagulation and amiodarone. The 3 months after the ablation, the patient was still in sinus rhythm, and which was nice actually that he's on the echo, the left atrium shrank from 5 centimeters to 3.9 centimeters. That was the result after 3 months from the ablation. The left atrium became normal, and still till now, the patient, after 5 years, the patient is still in sinus rhythm now of antiarrhythmic medication. I stopped it like 2 years after being in sinus rhythm, but he's still on WAG. This is the echo, actually, the transthoracic echocardiogram of his left atrium 3 months after the ablation. So is the MRI in atrial fibrillation I mean, like before planning for an atrial fibrillation, especially in persistent left atrium, some papers, some centers, they used it to explore actually to use, because there have been different strategies. There is in the task force of a persistent left atrial fibrillation ablation, there are no single strategy which is with every operator actually is I mean, like everybody do it. So sometimes there are people who use only the low voltage area. Some operator do the posterior wall as part of the left pulmonary venous isolation. I mean, some people, they do the whole box lesions, and there have been also people who use the jumping technique. But I think the MRI in some procedure, normally the MRI don't have a software designed to explore the nature and of atrium, but some operator actually, they can, especially experienced radiologists, they can tell you about it. So as I told you, why the posterior wall here in this patient? And some actually operators, they prefer to do the posterior wall actually in persistent atrial fibrillation. because the posterior wall embryologically is considered a part of the pulmonary veins. You see, embryologically, actually, the left atrium, the whole left atrium, and the whole right atrium, they don't come from embryologically from the tissue of the heart. Actually, it is the anterior wall in the appendage come from the tissue of the heart embryologically, while the posterior wall it comes from the tissue of the lung together with the pulmonary veins. So there are some operators, some centers actually even, but I think it's quite rare actually, even that in paroxysmal atrial fibrillation, some operators they go for the isolation of the posterior wall because they consider it a part of the isolation of the pulmonary veins, as they consider. But I mean, it's quite rare. But the posterior wall, as we all know, that the pulmonary veins they are not only the trigger of paroxysmal atrial fibrillation, but also they are a substrate because a substrate for an arrhythmia. As we know, it's different tissue with different conduction properties, electric conduction properties, different from the heart tissue. And there is a lot of anisotropic conduction here, like imagine like the crista terminalis, for example, in the right atrium. So the posterior wall with the pulmonary veins, actually, they have different electric conduction characteristics, different from the anterior wall of the left atrium. So the pulmonary vein, so the posterior wall, actually, it's very seducing to do the ablation for it as part of the pulmonary veins isolation in the persistent um, atrial fibrillation ablation. Of course, there are different techniques. Most of the techniques that we use actually is which is B, which is aligned after doing the WACA, which you can see it on the example of the B, doing a line from the left superior to the right superior pulmonary vein, and another line from the left inferior to the right inferior pulmonary vein. Some people they do just the walk and then they do an extensive ablation of the posterior wall, like we can see it in the C, but this is associated with high risk, especially of atrial fistula. And I don't think, I mean, it was presented as a technique in the very beginning, but they don't use it anymore. And some people they do like a big waka containing the left inferior pulmonary veins and the right inferior pulmonary veins, including including the posterior wall. But actually, it's when you control it with the voltage mapping. After this is a lot of gaps. So uh, why the patient actually happened to be in the sinus rhythm now for 5 years after the ablation? As we all know, we have the tachymyopsy. This tachymyopsy, normally we use it in the practical and day-by-day basis too, when we say like there is a PVC or a ventricular tachycardia concerning the ejection fraction, but also the atrium can undergo a tachymyopsy. The more that you leave the arrhythmia is going on, there is an electrical remodeling and anatomical remodeling on the atria, and that's why actually it goes from paroxysmal with less frequent attacks to more frequent paroxysmal attacks, and after this to persistent atrial fibrillation. If you don't intervene at a good time, it might go to chronic atrial fibrillation. And that's why it's better actually, once you decide that the medical treatment is not working, try to ablate the paroxysmal atrial fibrillation before it becomes persistent. And with the results that we are having now with the different techniques according to the preference of the operator, even if it's persistent, go to ablate it before it becomes chronic, and it's impossible after this to stop it and put the patient back into sinus rhythm. Thank you.
Thank you, Dr. Muhammad. I have one question. If you have this case today,
Okay.
you will keep your choice for CARTO or you will think about BFA?
I think I'll take a PFA because it's easier and I can do the posterior wall without doing all this. Especially that the posterior wall is scary a little bit when you ablate it. And, you know, at this time I didn't have the ablation access, but I will, I mean, now we have it, but again, still there is a risk of atrial fistula, and we don't have the ways to monitor the esophagus and the temperature and cooling it in Egypt. So no, I will go for a PFA.
Even after 5 years without no episode of paroxysmal AF, you will go again for PFA.
After 5 years,
لا
yeah, because actually, when I've seen the result of the MRI, I knew that I was going to do a waka on post pulmonary veins and isolate the posterior wall. So, I mean, like I put my strategy even before going and plan the procedure. Yeah.